hair panel discussion, moderated by Dr. Jawahir Al-Nakbi. The panelists are Dr. Sergio Vanyo Galvan, Dr. Michela Starace.
Assalamu alaikum. Good afternoon, everyone. Thank you so much for your valuable attendance. And my pleasure to welcome our international hair experts, Dr. Sergio Galvan from Spain, hi, and Dr. Michela Starace from Italy. Nice to meet you and welcome here in Dubai, and hope that you are enjoying also your stay. So this session actually will be for 30 minutes. I'm going to present 3 clinical cases to highlight the importance of diagnosing hair problems, and of course to have a good plan or proper plan to treat our patients and get great results. So the first patient, 42 years old lady, presented with 10 years history of progressive bald scalp. Actually, she visited number of dermatologists and been treated with oral finasteride 5 milligram per day for 3 months, and also topical minoxidil 5% spray twice a day, and baricitinib 4 milligram for 3 months. And she had poor response, and she was not satisfied. And she was unfortunately not compliant also in continuing such medication, because she thought that these kind of treatments were for short-term use. So here we have the clinical pictures for the patients. So what do you think, Dr. Sergio? What do you see here on clinical pictures? What are the findings you see?
Well, what I can see in that pictures, macroscopic pictures, is like a hair loss in the frontal mid-scalp, like with the distribution of male androgenetic alopecia. There's a form of alopecia areata called Sisypho alopecia areata, which is like that kind of pattern. So it could be. Of course, we always love to have trichoscopy, but it would be my proposal.
Absolutely. So you are thinking to use also dermatoscope or to do trichoscopy exam to have more details or more findings to help in diagnosing such hair problem. And what do you say also, Dr. Starace?
Yes, I agree with Sergio, but it's very important in this case is also because there is not a great result to have the trichoscopy, as we showed this morning, because it can help so much to understand the activity and maybe to change something about the therapy.
Okay, so here we have also a picture for the trichoscopic findings. So what do you see here? Anything can help you in diagnosing the case?
Oh, yes. In this picture, we have surely the diameter variability, so there is absolutely an association of androgenetic alopecia. In addition, we have a lot of empty follicles that are this yellow discoloration that can be also a diffuse alopecia areata, maybe together, because it's very severe.
Okay, what do you say also, Dr. Sergio?
Yeah, totally agree, totally agree. I think that it has been described perfectly.
So, okay, so do you have any accurate diagnosis for the clinical findings plus trichoscopic findings? So what's your diagnosis?
If we have, sorry, because it's a little bit of echoing. The diagnosis.
The diagnosis.
I mean, I agree with Michela. I would bet for probably alopecia areata plus a component of androgenetic alopecia.
Okay, so this is good first impression. This patient actually was on baricitinib 4 milligram, but didn't get any improvement. So are you thinking that or planning to do biopsy, skin biopsy to confirm your diagnosis? Is it going to help you to get the accurate diagnosis?
Well, this is like a topic very controversial, at least in my clinical practice. I hope that there are a lot of dermatopathologists here, but you are going to come with me to Madrid. No, but in clinical practice, we don't perform a lot of biopsies in our clinical practice in hair disorders because with trichoscopy, we usually have the almost have the diagnosis. And if we don't have the diagnosis with trichoscopy, I prefer to jump to a therapeutic proof, like injecting steroids and to see the response, because sometimes the biopsy is doubtful, but of course sometimes can help. In that specific case, I would not say that that the diagnosis could depend on the no response to the treatments, because the duration of the treatments is really short, only 3 months. You cannot consider a patient non-responder to that kind of treatments, either baricitinib or even minoxidil and so on. So yes, of course, the biopsy would help, but for me it's not like the definite proof.
I see. So here, the doctor or dermatologist who saw the patient took biopsy to help him in diagnosing such case. So what do you see in the biopsy?
In the biopsy, you can see that in the horizontal section, in the first, you can see that all the hair follicles are representative, even if there is the variability also, because in the single ostium, you can see a different diameter of each hair. And on the other side, in the south part of this piece, you can see that there is the representation of the sebaceous gland, so it is not a cicatricial alopecia. You can see the typical infiltrate of alopecia areata. So it's confirmed the diagnosis, absolutely, that both conditions can in this patient is together. But I think that trichoscopy, if you have a good knowledge about it, permit avoiding to do a lot of biopsy, to have this invasive way. Also because the patient in this period, they are not so happy always to perform it.
I see. So if we can ask also the audience, we go back also to the trichoscopic. So what do you think about alopecia areata or androgenetic alopecia? Dr. Ahmed Al-Isa. I see. Okay. It's not zero. Anyone can think? So I agree with the doctors. You see variable hair diameter. This is one thing. Also, you see even the follicular unit has single hair and yellow dots. And also, the number of follicular units are much less. Actually, what they also decide that it goes more with androgenetic alopecia. But we cannot exclude totally alopecia areata. So there was poor response to baricitinib 4 milligram. And the patient was on finasteride 5 milligram only for 3 months and topical minoxidil spray 5% twice daily. But she had no results. So what's next? What would you do with case of androgenetic alopecia in a diffuse form? Would you continue with the same to give a chance for these kind of medications? Would you adjust the dose or to add other treatments?
I don't know.
Well, in that particular case, I mean, I would wait a little bit. Of course, I guess that if we are talking about this case in the Congress, it's because we are going to add something. But for me, that baricitinib doesn't produce response after 3 months is something that is quite normal. There are early responders, late responders, even until 8, 9, 10 months, you can observe regrowth. And for androgenetic alopecia, it's true that with topical minoxidil, sometimes you can see that early response. I would go with that patient in that case. I mean, if I receive that patient after 3 months with this data, I would add oral minoxidil, I would wait with oral baricitinib, and I would perform like a therapeutic test, injecting triamcinolone in one part, just because alopecia areata usually responds very well even in one area to injections of triamcinolone. But I would have more patient and wait a little bit to see the response.
Exactly. So the time is very important. So we can try also again the minoxidil topically for a longer period, or even to shift to oral in case we need to have also, if we see a poor response to the topical spray. So as a case of androgenetic alopecia, again, we can think about the time to explain to patient how the compliance in using such medication is very important. Moving now to the next case. Here we have 18-year-old girl presented with 3 years history of diffuse hair loss. And you can see here, this is the clinical pictures. Assume that this patient came to you, she's 18 years old with diffuse hair loss. What do you think about this case?
If you look at the clinical, I think that is not easy to look at it immediately, because you have the first point for me, it is this bizarre aspect, because it is completely different, even if it is so similar, but it's different from the previous one. It's a young patient,
yes.
And if it is a severe androgenetic alopecia, it's impossible. So at this age, it's a very big history of a hyperandrogenism and
Agree.
a lot of deficit and so on. Alopecia areata can be also together, but I think that the trichotillomania is absolutely present, because you know, especially in the back, on the occipital area, you have too much hair with the different length.
Mm-hmm.
But
Dr.
trichoscopy
Sergio?
can help.
Yes, yes, I agree. Dr. Sergio?
Yes, totally agree. I was thinking and talking to my residents the other day that when you see a lot of patients with hair disorders, trichoscopy is really important, but mainly for confirming the diagnosis that clinically you have also performed. And in that case, I think it's typical the age, totally agree with Michela, the age, the distribution, that kind of a different length of hairs, that above yes, the ears, there's like apparently good regrowth or good hair density, and in the rest, that diffuse pattern.
Mm-hmm.
So yes, probably with trichoscopy we will confirm the diagnosis with more, with more reassurance, but yes, I think that I agree with Michela.
Yeah, it is very important what Sergio told, because it's important also for a good application of trichoscopy that you have a suspected disease on the clinical approach before to go with it.
Exactly. So your first impression is the trichotillomania for this young girl. We have here trichoscopic examination. So what do you see here, please?
On the trichoscopy, you can see the different length of the hair, that it's typical of a trichotillomania, because it is not an inflammation altogether as an alopecia areata, but it's the different day that they pull out. So you can see the different length. There are some wool sign there and some flame hair. And you can see the typical rotation of the hair due to flame hair. It's very typical of the pulling out with force.
Dr. Sergio,
and there is also hematic residual, it's a bread.
Yeah, I think that in that cases, when we see in the books that pictures with a lot of colors, like indicating specific signs, for doctors who are not like really experienced in trichoscopy, it can produce a mess. But I would give the advice to them that we see like different lengths of hairs, and this is something which is quite typical even without knowing anything about trichoscopy. And these kind of flame hairs, as Michela said, are quite typical of trichotillomania. But mainly when you see an image of alopecia areata or an image of trichotillomania, one of the first things that draw your attention is that different in length.
The chaotic aspect.
Yeah, so the trichoscopic findings are almost clear here, favor trichotillomania, and as you see here, exactly what we found in this case, the coiled hair like with the hook-like appearance and also with jagged end, and the V sign we can see in some cases, also the hair powder because of the total damaged hair at distal hair shaft. We have also what is called trichopliosis, where you see the longitudinal splitting in the distal end hair shaft, and we have also flame sign or flame hair because it gives also appearance of the fire flame and also the tulip appearance. And this actually case, do we need to take biopsy for such case? Do you agree?
For me, no, because it is very, but if you perform the trichomalacia that is present in this picture, it's very typical of trichotillomania.
Agree to take biopsy for this case? No. Can we have mic for our audience, please? So you all agree that we don't need, or this case is not indicated to take biopsy? Dr. Ina?
The trichotillomania, the denial is the challenging, because they deny, and once you tell the mom she's pulling, she gets mad from me. She said, no, we are a good family, we are not psych. So the only thing I said, listen, I might be wrong, we'll do biopsy, and then the biopsy will tell us. Yes. And then they say, oh. Otherwise, most of the family, they didn't like to tease them that she's psych. So the only proof is biopsy.
Yes.
I totally agree. I would not perform biopsy here because perhaps in our case we would not, or they would not, put in the report suspicious of trichotillomania. But I was thinking that my main indication of biopsy follows that concept is patients with fibrosis and alopecia in a pattern distribution that comes to the consultation requesting a hair transplantation. And we say, you have a cicatricial alopecia, and it's like the justification biopsy to show them that they have a cicatricial alopecia and that probably they are going to have worse prognosis in the hair transplant, and this is like the objective proof. But it's true, if we had like a higher degree of specificity and sensitivity, we would perform more. But yes, I think it's very relevant also as Michela said, like the clinical diagnosis that you talk to the dermatopathologist that you are suspecting. For example, another interesting topic is that the lichen planopilaris, the post-hair transplant lichen planopilaris. I think that if you tell to the dermatopathologist that you have a very high suspicion of lichen planopilaris, they can also see like the fibrosis of the hair transplant, and they can like say that it's concordant, compatible with lichen planopilaris, or the opposite. Well, in that case, I think it would be useful. But personally, I would not do for logistic reasons.
I will say a trick for treatment, which I find it very useful. Giving psychiatric medication, it's very difficult in certain families. So usually the mom resists, the dad agree. So I tell the dad, listen, we'll make agreement. I ask my psychiatrist, what should you do? And he's telling me this medication is good. So we give her this medication as a hair treatment, not as psychiatric treatment. It works well. And then in 2-3 months, she starts to get less with that compulsive, message for herself to pull the hair. So, but giving the antipsychiatry, it's an insult and in certain families.
Yeah, trichotillomania really is a challenging hair problem. Absolutely, we respect the collaboration between dermatologists and psychiatrists to treat such cases. Dr. Inas has a comment also. Please, would you give her mic?
Yes, thank you so much. I would like to stress that we have to examine the whole scalp, the whole field with a trichoscope, because the presence of trichotillomania doesn't exclude the presence of another pathology. And I saw cases of alopecia areata in one spot, and then due to the psychological element or so, they have also another psychocutaneous disorder. This one thing. The other thing is that the presence of trichotillomania by itself, it can expose the patient to other self-inflicted skin lesions. So we have to examine the whole patient, because many of these patients, they can have also onychophagia or skin picking disorder or neurotic excretion or any other psychocutaneous disorder. Thank you.
Thank you, Dr. Inas.
Just to add, it's very interesting because it's true that in clinical practice, I have not a few patients with alopecia areata that they also have signs of trichotillomania, because they become like a little bit crazy, like scratching and trying to do the pull test if they for checking if they have activity, and also other patients that they have like a baseline alopecia areata and they start to scratch the skin and they develop a chronic lichen and they produce like the signs of trichotillomania, and it's sometimes quite confusing, but you have to think about what is the most probable behavior of the patients in that case. And it's true also another typical thing of trichotillomania is like sometimes like traction alopecia, that the patients lie, the patients deny that they have that kind of hairstyle, and they come to the consultation with the hairstyle.
So I think that's what we experience with our patients. So how will you treat such diffuse trichotillomania in young age?
It's a very severe cases. I think it's very important to explain the patient what it is happens and how it is possible to improve without any avoiding to touch and to pull out. It's very important because sometimes they denied, it's very frequent, absolutely. On the other side, they didn't understand that this action induced this severity. It's important to send it for a counseling, for the use of the bracelet and all of the other. The N-acetylcysteine, it's very good option, especially in children where it is not easy to prescribe psychiatric drug. But after a few months, after 1 year maximum, if you not have enough result, you have to ask the consultation of a psychiatric to try to prescribe psychiatric drugs to try to avoid, because if you, as an intractional alopecia, if you start to pull out for a lot of time, there is the risk to induce then a cicatricial. So it's especially in very young patient and in very severe cases.
Dr. Sergio, yeah, please.
Yeah, totally agree. I was wondering, I mean, I don't have a huge experience in trichotillomania, but of course we have used all the psychological approach. I think the important thing is to detect if there's like an associated psychiatric disorder. That is the most important thing. And I wanted to raise the question, I have used N-acetylcysteine without no result, or I don't know. It's like, I think it's more important, perhaps, if you prescribe a treatment to a patient, he becomes more aware of the importance of pulling the hair. But I don't know if anyone in the room has like a clear good experience with N-acetylcysteine. But personally, I have not had good experience.
What about using minoxidil, either topical or oral, in such severe case or diffuse case of trichotillomania?
It's a very good option
treatment.
Also to include, I prefer to use in these cases oral minoxidil than not locally, because less touch your head, better it is for the patient. So in this case, the result is the same. It's not high dosage, low dosage, as Sergio always told. And I think oral minoxidil is better, absolutely, to enhance the velocity of the hair regrowth.
Any other options of treatment will you think about diffuse trichotillomania? Thank you. So moving now to the last patient. Here we have a 45-year-old lady presented with 2 years history of hair loss at eyebrows and also some facial lesions as papular form. So here you can see at the baseline, patient presents with papular lesions all over the face and hair loss at eyebrows. So what do you think about this case? She's 45 years old.
Well, I think, at least in Spain, this is like an epidemic, so it's an FFA until it's demonstrated the contrary. In fact, I can remember when I finished my residency a long time ago, that I started to receive patients with isolated diffuse eyebrow loss, bilateral, and then what it can be, and then we perform a little biopsy, cicatricial alopecia, and we had like a lot of patients, female patients, like 40, 45 years old, diagnosed with eyebrow lichen planopilaris. And then we realized that after that, they had, many of them, like this case, facial papules, and they started to develop like the hair loss in the frontal or temporal areas. And for me, even like, the criteria that has been published regarding FFA for the international group, but when I see a patient with this diffuse eyebrow loss, for me it's like the beginning of a frontal fibrosing alopecia, and I start the whole package of treatment.
I see. So how common is the presentation with papular lesions on the face? Do you see with FFA?
How?
No, how often or common to see papular lesions?
Not so frequent. I think 30% of the cases, 1 to 3. Maybe I look at it, but I have not a great experience. Maybe in dark phenotype, it's more present than in Caucasian, almost in Italy. I don't know in other country, but it's more present.
Mm-hmm. Okay, here we see all together over the slide the trichoscopic findings for this patient. So would you just describe what you see?
It's very easy to recognize. That is a very typical cicatricial alopecia. You can see first of all, and it is an FFA because you have a completely disappearing of the vellus area, the intermediate area. It is typical of the trichoscopy in FFA because there is the beginning directly of the terminal hair. In these cases, we have also the typical perifollicular hyperkeratosis that induce the activity of the disease. You can see also the red area together with some white areas of the typical aspect of a cicatricial, and some residual because it is possible to remain, especially at the beginning, some residual dots that are not a complete destruction or absence of the follicular ostia.
That's great. Dr. Sergio, please.
Yeah, no, I totally agree with Michela. Is the wise of trichoscopy. No, I was coming back, remembering like some curious clinical presentations because when I remember the first man that I saw with frontal fibrosing alopecia. I also diagnosed him with the combination. It was crazy. The combination of diffuse eyebrow lichen planopilaris plus body alopecia, body hair alopecia areata, because he had like the typical patches, and after a few years, it was like perhaps 2012, after a few years, like you realize, and nowadays you will say it's a clear frontal fibrosing alopecia, but yes, now the trichoscopy thing is quite clear, and this is another like interesting controversy regarding biopsy, because for example, we only perform biopsies in FFA for research purposes nowadays.
And here we are.
There are usually no doubts. But for example, in some colleagues from Brazil and so on, they perform biopsy to see the degree of the inflammatory infiltrate. And depending on this, they prescribe one treatment or other. I mean that the biopsy decides one treatment or the other. And for us, it's not that important. I don't know if Michela...
No, I completely agree. You can use trichoscopy also to understand the severity and the grading of because on the basis of the hair cast, hyperkeratosis and so on, the residual, the follicle, you can select the right therapy. I absolutely agree also because we perform biopsy only for research, only for clinical study. It's not useful to do biopsy in FFA because in this case the clinical suggest that this type of cicatricial, trichoscopy confirm, and trichoscopy give you all the severity, the grading of the inflammation.
So that's why we are highlighting the importance of using dermoscopy to help in diagnosis such hair problems. So also the biopsy confirmed the FFA. So how would you treat such case? What kind or options of treatment to treat FFA?
We want to
forget about the list that we have. So assume that the patient came to you with this diffuse hair loss and you confirm the diagnosis clinically and by the trichoscopic features. So how would you treat her?
Well, as I said in the other lectures, I think that the protocol nowadays based on the scientific evidence, of course, there are not clinical trials, so the level of evidence is not a 1A. But as I always say, we are not going to tell to the patient, no, we don't have meta-analysis, so go home, and I'm not going to prescribe any treatment. So the mainstay of treatment is like anti-inflammatory treatments. It can be topical or oral anti-inflammatory treatments, mainly pimecrolimus, topical calcineurin inhibitors, or tacrolimus, maybe topical or intralesional steroids. Or if you see a lot of inflammation, you can prescribe also hydroxychloroquine, and you usually add a 5-alpha reductase inhibitor to prevent the hair loss progression. And depending on the clinical features, for example, for facial papules, the oral isotretinoin is really effective. So for me, that treatment is really suitable. I would perhaps only add oral minoxidil instead of topical minoxidil for improving the compliance of the patient. But I think that with this treatment, probably the patient can get stabilized with a high percentage.
Dr.
Yes,
Michela?
I agree with Sergio, but also with this suggestion. At the beginning, it's the first approach. Maybe intralesional is not my first choice for steroid. I prefer to use systemic steroid. Maybe if there is only single area, small area, maybe intralesional. But if I have all the hairline, I prefer the systemic to be sure that all the area it is treated, also because it's a cicatricial, back it is impossible to go.
What about the papular lesions, the facial lesions she has? So how will you treat it?
And the papular lesion are a very good response with the isotretinoin. The problem is also for the Brazilian group that studies so much the therapy of these facial papules because it is more prevalent in that phenotype. It's when you stop the histotriptylin, usually they come back.
I see. So this patient been treated with oral dutasteride 0.5 milligram per day and also oral isotretinoin 10 milligram for the facial lesions. And they were using also intralesional triamcinolone acetonide every 2 months with dose of 2.5 milligram into the frontal hairline and eyebrows. But I agree that it's good to think about the skin thinning at the frontal hairline. And they were also, she was also on topical Dermovate cream, tacrolimus ointment, and minoxidil 5% spray. After 1 year, they have stopped the topical medications except the minoxidil, and here we can see the results with good signs of hair regrowth on eyebrows and excellent results with almost clear skin for the facial papular lesions. So here before and after with isotretinoin 10 milligram daily. And I can show also here, there is very nice international expert alliance here for the FFA. So it's really very important to have a proper history because there is in most cases positive family history of FFA, symptoms of hypothyroidism, and also the onset after the menopause. If we'll think about the treatment, we agree exactly for the scalp FFA, the systemic therapy, the finasteride, dutasteride, and also to have topical potent steroid, and to consider also topical minoxidil. And for the eyebrows, intralesional corticosteroid with dose of 2.5 milligram, topical calcineurin inhibitors, and for the facial papules, yes, low dose of isotretinoin and topical retinoids play a role in clearing the facial lesions. But for the stable cases, what would you do if the patient already on treatments for 1 year or even 2 years? What would you do with these kind of systemic treatments? Would you taper, would you discontinue, or just continue the same dose?
Well, this is like the art of individualizing the treatment. It's very different from one patient to the others because there are patients that you say, for example, after 2 years, there are some patients that start to ask, doctor, when are we going to stop the treatment? And then you say, okay, so let's start decreasing slowly. And there are other patients that are like 5 years, 6 years, totally stable. I start decreasing a little bit the dose of dutasteride, and then the next year they are with 2 capsules of dutasteride, 0.5 milligrams per week, and I propose to stop, and they don't want. They say, no, why? It's like, it's bad for the long term. No, it's not bad, you know. So, I mean, my experience is that if you stop completely the treatment, especially in the first 5 years, you can have some kind of relapse, and in fact, the most difficult thing in FFA, in my experience, is that we don't have an absolutely accurate method for evaluating the effectiveness of the treatments. So I mean, and the evolution is like very slow. So this is the problem because there are no really clinical trials very accurate, because to evaluate 2 arms of treatments or randomized with placebo, I think that we would need at least 2 years, and this is quite difficult when they design a clinical trial.
Yes, absolutely agree. There are some treatments that you never stop. As dutasteride, as minoxidil, you can stop absolutely reducing very slowly the steroid, and it is possible to use all for all your life. But the other treatments are possible to use for a long time, so it is not necessary. It's important to explain the patient before to start that this drug, it is better to continue, I think.
And just to add, I think it's very important, and we have participated in that studies, but in my experience, it's really important the type of pattern of frontal fibrosing alopecia, because, and it's usually not taken into account in the algorithm, but the pattern 2 is like, if I see a pattern 2 in the first consultation, my comment to the patient is just, so probably you are going to worsen, but we are going to slow down and to try that the worsening will be like slower. And in pattern 3, the one who is like maintaining the eyebrows and so on, you can be absolutely optimistic, because even without treatment, many patients are stabilized over time.
Very good. Thank you so much for the fruitful discussion. Any question from our audience? Any questions to our experts, hair experts? Dr. Sergio,
Thank
Dr.
you so
Michela.
much. I would like to ask about using oral doxycycline or hydroxychloroquine for such patients with active disease. Is it add-on or is it a steroid sparing?
So if I have understood fine, the use of oral doxycycline, so I have used it, but not so much in FFA. I use much more in folliculitis decalvans. The problem in FFA is that we have to maintain at least 6 to 8 months the treatment. It's quite used, I think, in the US, but in my experience, I would prefer other anti-inflammatory treatments. I used a lot in the past hydroxychloroquine, but the patients really are mainly postmenopausal, and they don't really tolerate well because you have to give not the dose of 200 milligrams per day, but mainly 400 milligrams per day. So I prefer, in that cases, to use very diluted intralesional steroid injections combined with PRP. And doxycycline, I think that, in my experience, is not that effective in FFA. I don't know, Michela.
Yeah, I absolutely agree. It's never my first choice. I have to think about it to prescribe only because maybe the patient is a cancer, breast cancer, that is impossible to prescribe dutasteride. Is some diabetic, severe diabetic, you cannot prescribe systemic steroid. So for any reason, you have at the end to arrive to prescribe doxycycline. Yeah. Also because it's a few months, you cannot take for 1 year. You can take for 4 months maximum.
Yeah, I'm remembering probably my most frequent indication of doxycycline in FFA is when the patient associates rosacea, and I start with doxycycline 3 months, and then I change to another treatment.
Thank you so much. So in the end of this session, I would like to thank Dr. Sergio and Dr. Michela for sharing your expertise, insights, and clinical approach in diagnosing such challenging hair problems. Thank you so much, and thank you for all.
Aesthetic Panel Discussion, moderated by Dr. Samar Khalil. The panelists are Dr. Ahmed Al-Isa, Dr. Naif Al-Nomer, Dr. Hassan Galadari.
Hi, everyone. Thank you so much for being here at the end of the day. I have the pleasure to be moderating the aesthetic panel discussion with esteemed colleagues, Dr. Al-Isa, Dr. Galadari, and Dr. Al-Nomer. So what's going to happen is that, as stated in the previous session, we're going to show you 3 different cases, of course, related to cosmetic dermatology. We'll be taking the opinions of our experts and see where they agree and where they disagree. So let's start with the first case. Before I give you any background story, Dr. Al-Isa, what's your impression when you see this picture? When you see such a picture?
Any injectable, ask those. Any laser for me.
Okay, so what I see is blood in the top of the syringe after the aspiration before doing a dermal filler.
All right. Do you personally aspirate or you do not?
So personally, I always aspirate in certain areas, like, for example, if I'm doing fillers for temples, if I'm doing fillers for the piriform fossa, if I'm doing filler in the medial cheek, I always aspirate, but I always keep in my mind, it's the false negative is there, it's a true positive. So if you aspirate and there is blood, that means you are inside the vessel already, it's either vein or artery. But if you aspirate and there is no blood, this does not mean you are not in the blood vessel. So I always aspirate in danger zones, but I keep in my mind it might yield a false positive.
100%. So unfortunately, with the aspiration, there's a high false negative rate. And here we can see the reasons. So 1 is collapse of the vessel wall because of the negative pressure when aspirating. 2 is the through and through phenomenon when the needle goes through the vessel. And 3 is the filler needle or pullback characteristics. So for example, if the filler is too thick and the pullback force wasn't strong enough. Dr. Hassan, I know what you're going to say, but do you aspirate?
I do not aspirate. I'm a non-aspirator. I believe it's a complete waste of your time, and it basically gives you a false sense of security. For an aspiration to be successful, there are certain criteria that has to be fulfilled, and has to be fulfilled to the T. And nobody's able to do that. The first criteria basically is that you have to stand still as you're pulling for at least, I would say, 16 seconds. You're not going to be standing still, you're not going to be doing it at the same time, and the patient is not going to be sitting still at the same time. So that in itself will not work. So that's one. The other thing is that it will also require for you to actually be in a place where there is a bony landmark. So, you know, he mentioned the temples, he mentioned the piriform fossa, that's fine. But we are, you know, I see people aspirating in the lips. That is also not going to work. So that's one of the things. And the final thing is that you also have to always prime the needle. That means every time you inject, you have to remove the needle, put another needle, and then aspirate. Nobody does that. Okay, so it's not going to work for you. And the last one, for you to actually also to see, we're not only using HA. It will work only with an HA because it's a gel. You'll be able to see the blood. But for example, if you're using something like calcium hydroxylapatite or anything that's a little bit colored or opaque, you're also not going to be getting it. So aspiration does not, it may work, okay, but it gives you this false sense of security. Exactly. So don't aspirate. For me, it's much better for you to know your anatomy and at the same time to know your technique. That's the most important thing. If you want to add a little bit of an aspiration, for example, as my colleague here said, well, not just my colleague, my friend, okay, if you're doing it in the temple and the piriform fossa, that's fine. But, and I will say this, I'm going to use this analogy, it's the same thing as if you are wearing a raincoat every time. The phone tells you that it's sunny outside, you go outside and there is no cloud and it's sunny, but you're still wearing a raincoat thinking that it's going to rain. Okay, that's exactly what aspiration means.
Since Dr. Hassan mentioned the time, how long do you aspirate for when you aspirate?
And how many seconds do you?
Again, like Dr. Hassan said, it's the false negative is there, but I aspirate for 5 seconds.
Okay.
But again, I keep in my mind always the false negativity. It's if you think it's gonna give you a secure injection plane, it's wrong. I aspirate because like I'm looking for this 5% chance. Maybe I will have some blood, so I will have. But I'll keep in my mind if I aspirate, it should be 5 seconds at least, and it should be a new needle. It should be a new needle at each time, because if you prime the product, if you aspirate, the blood will not come. So aspiration is there, 5 seconds, new needle each time.
It's 5 seconds is not enough. For all the publications point out that it has to be at least 16 seconds. And I've never seen anybody inject and waited for 16 seconds. It will be very awkward. Imagine 16 seconds is very long.
You cannot wait 16 seconds at the same place at the same time, at the same plane. You
just proved my point.
Yeah. You cannot, yeah.
All right, so Dr. Hassan already mentioned other safety measures. So here we can see other techniques that an injector can use for a safer injection. So basically using a large-sized cannula, concomitant use of lidocaine with epinephrine to cause localized vasoconstriction, injecting a small bolus, injecting slowly, a low extrusion force, and of course selecting safer injection planes. What do you think about constant needle motion in the area?
Constant
needle motion, so moving your needle a lot so that you're injecting a tiny bit all over the place.
So usually if you know your anatomy and you know the plane that you are injecting, you should not move your needle while injecting, because you are injecting at a place that you want to volumize. Except if you are doing like a towering technique, like doing a bolus above a bolus, that's the time that I move my needle. Otherwise, I always keep my needle at the same place.
Dr. Hassan?
Now, there is evidence that says that moving the needle can help in a sense, but then, at the same time, when you move it, you also have to inject less than 0.1 every time you move. So it's a little small aliquot every time, and you mentioned this here. So you move it slowly and you inject a very small amount for it to actually be beneficial. But that being said, if you think about it, the more you move, the more chances for it to actually hit another blood vessel. So in my humble opinion, and I'm not a big injector, as people know. Okay, I would say that it's much safer to actually use a cannula.
Exactly. This study actually assessed constant needle motion and the safety of it. And they say that assuming movement occurs in all directions, both deep and superficial, the covered area would be shaped like a cone, as you can see in the picture, with the tip of the cone being the dermal access point. And they did a bunch of calculations, and of course this makes sense. The larger the cone, the higher the risk, as Dr. Hassan said, for encountering an artery, and the higher the risk to inject into the artery. So it's not actually as safe as some might think. So any final words about safety of filler injections?
Yeah, are you going to aspirate? Are you still going to aspirate?
Any advice
did
for
I not
young-
convince you?
No, no, I will still aspirate in certain areas if I'm hitting a bone. I will still aspirate for 5 seconds. I know it's 16 seconds. I will still do it, but the false negativity is there, but I will still aspirate.
Same here.
What about the audience? Who, you know, would you aspirate? No?
aspirate no harm. Do it. فيها أي harm in aspiration.
Hassan, it's a controversy with all injectors. I know. I totally agree with your point. It's the false negativity is much more higher than the true positivity of the aspiration. But in certain area, we have to do it. Even it will not guide you for the injection, but it will not harm you if you are doing it.
Yeah, same. Little alcohol is not going to harm you. Still, we don't do it.
لا حرام.
To actually go back to the picture, this was actually a picture that I took. I had just graduated and I was doing temple fillers on a medical student. So imagine what would have happened if I did not aspirate. I do understand that it's not 100% guaranteed, but I would rather do the maximum I can to be safe, and I would still take all the safety measures I can, but still, like I say, thank God I do it, because look what happened.
No, but you just mentioned it. You just graduated. That means your technique is bad, and also you
Not true.
And you just started.
All right, so now we're going to move on to the second case. So here we have a 67-year-old lady present. She basically wants to improve her appearance. Dr. Laisa, what would you recommend for such a patient and at such an age?
The problem is that we cannot hear you because of the sound. But
So the question, what I would do for this patient to improve?
She's 67. She wants to improve her appearance. What would you suggest for her?
I would refer her to my friend, a plastic surgeon, to do a facelift, honestly.
All right.
If she's against doing like an invasive procedure, but definitely she's a facelift case, definitely, I might do some biostimulators like PLLA or calcium hydroxyapatite to improve the quality of the skin with minimizing the patient expectation after the treatment plan. I would do maybe 2 to 3 sessions of biostimulation, but definitely she is not a case for injections.
Dr. Laisa, any lasers or energy-based
And I agree with Naif. This is a surgical. She might, the main thing she has is fat, more than collagen here. So she might need fat. She might need whatever injection, but I think none of my laser devices will help her. However, a biostimulator and laser both stimulate collagen. So I think none of those will make her happy. So either surgical or fat.
Mm-hmm. So this is actually Dr. Hassan's patient, and he did treat her. Can you tell us what you did?
And I wanted to comment, with Dr. Ahmed. So, what about in terms of skin laxity with all the new devices that we have right now? Would you do anything for this patient in terms of just treating the laxity? If, say, she says that she does not want to have any surgical intervention done.
Either laser or microneedling radiofrequency.
Yeah. What's on your...
And I think the main thing here is not only that, is fat.
Fat. Yeah,
so I think none of the devices with the stage of this will help her by itself. It might do any device with fat, maybe, but when I see such patients, surgical or fat. I will not change my. So none of those devices, the ultrasound or laser, I think will do much for tightening with this stage. Alico, maybe, which is the, but I think I have no experience with it, but from the photo I have seen, they have shown such things. So to make my answer short, surgery, fat.
All right. Dr. Hassan, what did you actually do?
So, so she was basically, I mean, I would agree. I mean, she's more of a surgical candidate, but the patient does not want to have any surgery done. So we had to combine different treatments that were considered to be non-surgical. So we did combine 3 distinct treatments, and we treated aging in different multi-layer approaches. So we did utilize deep fillers, so volumizing fillers, HA fillers were utilized in those patients, in her mid-cheeks mainly, as you can see, and also across a little bit of the jawline. This was topped up by calcium hydroxylapatite, which is more or less a biostimulator, as Dr. Naif was mentioning. And then finally, we also treated her with microneedling and radiofrequency machine. So she underwent 3 different sessions for that, and we covered both her face and also her neck. Her neck was also treated also with hyperdilute calcium hydroxylapatite to provide a little bit of rejuvenation effect, and you can see that.
Mm-hmm. Dr. Numair, how would you, when using biostimulants, do you change the dilution or the number of sessions based on the age or the...
So basically, if I'm gonna inject this patient, definitely the product of choice will be calcium hydroxylapatite with HA filler, which is hybrid filler. I would use like, it comes with 1.5 cc. I would add maybe 0.5 lidocaine only, and then 2 cc of HA filler. It would be like medium cross-linking, I would say, for definition and lifting rather than having like low molecular weight HA. Maybe I will treat her skin quality later with like skin boosters and others. But definitely, if I would like to use fillers in her case, I would use hybrid filler to give definition and volumization, especially for the jawline and the medial cheek.
Very good. So next patient is actually her daughter. She's a 41-year-old lady. And again, Dr. Laisa, she presented to you. She wants to improve her appearance. What would you do?
That's case 3, by the way. It's not case 2.
No, it's this part of the same case.
Okay.
So what would you do?
What would you do, Dr. Aisa? Any laser recommendations? Any?
Wallah, she looks very beautiful.
he will give her his number.
لا يعني, what's her request for what?
She feels that her skin looks dull, and she feels like she could be a bit more lifted.
Well, I'm a very selective physician. I don't inject anything I cannot dissolve. I'm from the old school. I'm still hyaluronic acid and fat. So I don't inject anything from those new because I don't know what will happen for future. I'm seeing every 2-3 months bad granuloma. So I will be very careful about those new agents, but I respect all my colleagues' job. But I think if I want to do something here, I will do from peel, cream, but none of the devices that I think will help her.
Any non-ablative laser would you do? For example, like an ND-YAG, say for example?
ND-YAG,
She's
1927.
Exactly.
Question, she need tightening? Why should I tighten someone like this? She's young.
But she has a prominent nasolabial fold.
Dr. Ahmed is rich.
Is there any strong data about these things to improve? I guarantee you, if I give her peel and topical retinoid, I see her in a few months, she will be perfect with the less cost. Yeah.
How do you manage if a patient is really insisting on getting injectables and you really don't think they are a good candidate? How do you manage their expectations and how do you convince them that the natural approach is the best option in this case?
So glad that we have translator. So because I think the Dubai language need someone. So we are foreigners.
We cannot hear you.
How can he hear you and we don't hear?
Managing the expectation is very easy if you set up the expectation before the procedure. So for this patient, if I had this patient, for example, coming, and I know those patients, they will come and say, "Doctor, what do I need?" And then in this consultation, definitely, I would say maybe a little bit treating the tear trough and improving the nasolabial fold and improving the quality of the skin. She has a little bit of transverse line over the neck, which is very difficult to be treated. Maybe we'll treat it with hyperdiluted calcium hydroxyapatite or polylactone injection. But definitely, I would say for this patient, before I start any treatment, you don't need anything. You are beautiful as is. I'm just gonna do a little bit of improvement of the shadows under your eyes and the shadows of the nasolabial folds. Lips is always good for female, but I would not do maybe HA fillers for the lip. Maybe I will do toxin for lip flip.
All right, Dr. Hassan, what did you do?
She did her lips. So this is also my patient, since both of them came together. She looks better. See, there you go. She looks better. I told you, I don't do a lot of fillers, but the fillers that I do, they turn out like this. So we did put a little bit of filler, as Dr. Naif was mentioning, just a little bit underneath the tear troughs. You can see that it's gotten a little bit less. Her nasolabial folds got better because of a little bit of a lift of the cheeks, but I did not inject her NLFs. And I also treated the areas of the marionettes. We tend to forget the marionettes, or the areas around the perioral areas, and I put a very medium G prime filler into that area, and at the same time she also wanted to do a little bit on the lips, in which we also did, and of course a little bit of no, this is not topical. There's no topical here, no topical, and botulinum toxin, of course.
This is immediate after, right?
This is immediate.
Yeah. Immediate after, because of the swelling of the lips. Okay.
All right, thank you very much. So both patients left the clinic very happy, as you can see.
Yeah, they came and saw me after that, and this is how they look like, both the mother and the... You can see her lips now have become a little bit better.
That's why I'm asking.
All right. So now we move on to the third case. This is a lady in her late 50s, and she's had multiple lip filler injection sessions, and after many of those sessions, she's had recurrent swelling, sometimes with purulent discharge, and she keeps insisting on getting lip fillers because she simply doesn't like her lips. So what do you think is going on here, Dr. Laisa?
What do you think? She's insisting she wants fillers now.
So recurrent swelling after lip fillers with multiple injectors, multiple filler brands.
But what would you do? So you cannot do fillers because she's getting complications. So would you do something else?
She's not my territory. I will not see those patients. I prefer. I'm a laser guy.
Would you do any laser for her?
No laser, I say, no laser.
No laser, okay. Nice.
Why you are starting with me all for all the cases? So definitely from the look of the lips, there is irregularities, there is like some nodules. So I would say if she's insisting in doing fillers, I would just convince her that we need to treat the nodules and the irregularities first, by either using hyaluronidase, covering her hair with antibiotic if she has like that swelling and erythema and the discharge, for example. And then after treating all of this, I will give them always 3 to 4 months and a period of no fillers to check if they have a recurrent swelling or no. If they don't have recurrent swelling for 4 months or 3 months, then I might come and do fillers. But definitely for this case, if I have it in my clinic, I will not touch her with any fillers unless I treat the pre-existing areas by using hyaluronidase or steroid or antibiotic, depending on the presentation at that time.
Dr. Hassan, what's your diagnosis?
What's my diagnosis? I mean, I can't really tell you. I mean, is this a biofilm that's actually forming, or is this a granuloma that's actually forming? It's very difficult to tell unless pathology is actually made. So, I mean, you have to do a
biofilm, it can be granuloma, it can be infection, so.
All right, so the patient actually underwent multiple swab cultures and they were all consistent with normal bacterial flora. She also had a swab for herpes, which was negative, and she also did an echo Doppler, which did not show any significant findings. What do you tell such a patient who keeps insisting to improve the appearance of her lips? What other options does she have?
I told you already. I will bring her in, cover her with antibiotic first. I will do hyaluronidase. I might use oral steroids, 0.5 milligram per kg as a coverage if she has like any swelling afterward, and then I will see her for another session if she still has the same lesions, and then I will inject her with HA fillers.
So you would try again?
Yeah, I will try again. Yes, I will try again using a good product. Using right technique.
Restylane, Juvederm?
Huh?
What other good products do you want?
Wrong technique.
Wrong technique?
Not knife.
Dr. Laisa, how about laser lip rejuvenation?
Laser lip rejuvenation.
The only laser I use for lip in pigmentation, but for rejuvenation, I don't use it at all.
Fractional laser.
However, yes, no, even fractional. I don't use fractional except for the wrinkles, linear for the peri-orbital. But I do lip pigmentation a lot. But I don't do any rejuvenation laser. Simply, we don't have much smoker, ladies, and we don't have the elderly, those we see in Europe. We don't see much of the peri. Otherwise, I used to do erbium, CO2 for those. But now, after Botox, I'm doing well with the wrinkles. But I don't do rejuvenation. It's not in my terminology.
Why not? You don't think it will be...
Sorry?
You don't think it will be effective or the patient would be happy with the, for example, fractional laser?
It might be, but I don't do it.
You don't do it?
No, I don't do it. I do only lip pigmentation and erbium or CO2 for the periorbital wrinkles. That's it.
But it's very difficult to comment in laser with the presence of Dr. Ahmed, but I do sometimes, if they have a fine lines over the lips, I do fractional laser, CO2 fractional laser with low parameters. Like I decrease my parameters, the power, and I do 2 passes. But you have to select those patients. You have to look for a sign of hyperpigmentation if they are like, they have tendency of hyperpigmentation. Usually I look to the angle of the mouth. If they are hyperpigmented a little bit, I usually don't do it. But in skin type 2, 3, I do it for only improving the fine lines over the upper or lower lip.
All right, so our options are basically laser or trying to re-inject after a while.
No, hold on. I mean, you can't maybe augment her lips, but maybe if she wants to rejuvenate them, I mean, you could technically inject, for example, polynucleotides. Now, would polynucleotide work? I mean, Dr. Ahmed would say there is no data, but you know, it depends, and you could basically do it, and because the patient wants something to be done. You're not. What we learn is that we first do no harm. If we know that it's not going to cause any harm for her, money harm?
Yeah, there's no harm.
دكتور أحمد ماخذ جلدية بالهواية. It's a hobby for him.
Who think money harm? It does. She pay you for something that you say there is no data.
Okay, but you know, but there is data in terms of the rejuvenation part. Maybe there's no data in the lips themselves.
Sorry, I'm old school. Enjoy the money.
That's
not. Anything has no data, I will not do it for my patients. Of course. No harm. Money is harm.
Okay.
Doctor,
if you have a sample of polynucleotides, you can use it on her. She won't pay.
Does anyone have experience with polynucleotides in the lips? All right. Dr. Numair, just one question. If you were to re-inject her after a while, would you give her prophylactic antibiotics or?
So injecting lips does not need prophylactic antibiotic if you use if you like use a clean technique. It's not aseptic technique, a clean technique, using like a good product. There is no pre-existing nodule or abscess that does not need to be covered with antibiotic.
All right.
Personally, in this case, given the fact that it's repeated, I may think about doing it. I may give her probably an antibiotic just to be on the safe side. But he's absolutely correct. There is no necessary need for it. But in this case, get the fact that she's had it multiple
times over years and with multiple injectors, multiple brands. She's really desperate. She's actually considering fat grafting in the lips.
Would you do fat grafting, Doctor?
No, I don't do that.
Would you consider?
Yes, because it's the safest.
Yes, he said yes.
He said, would you do it? I say, no, but I know fat is safe relatively among the other because it is the safest since it's from your body, for sure. And I have I'm an excellent plastic surgeon who does it. So he always tell me, anyone who has any reaction from any kind, fat is the safest if they insist to do it.
Definitely, autologous fat is the safest, definitely. But it's like, especially in the lip. So I would consider fat in any areas, which is I would put autologous fat transfer one of the best thing to be done to the patient, but it will not give definition. It will not give shaping of the lips, protrusion of the lower lips. It will not.
If she didn't like it, you cannot take it off. This is and again against fat. Yeah.
All right. Any final words?
Any final words?
Thank you.
Thank you very much. I actually love the discussion and that you did not agree on everything. We have the more conservative approach and we have the more...
So this is the beauty of the panel discussion, that we agree to disagree from the beginning.
I just learned also something. I learned that I will open a clinic next to Dr. Ahmed's clinic, so I see the patients he doesn't want to see them.